Good morning, everyone, and welcome at the European Policy Center. My name is Elizabeth Kuiper. I'm the Associate Director and Head of Program of the Social Europe and Wellbeing Program at the European Policy Center. And I'm very happy to welcome you this morning at the online policy dialogue about building a European health union, opening borders for intensive care specialists. We have a really interesting panel for you, and I think especially in time where we're still talking about the lessons learned from COVID, but also certainly looking to the context we're currently in with a lot of issues to do with health workforce. We are counting on you as the audience as well to have an interactive discussion with us about all the issues at stake currently. But before we go to the panel discussion, I'm very happy to give the floor to my colleague Danielle Brady to lead us through the findings and the recommendations of the European policy brief, the European Centre's policy brief, because Danielle, you led a really interesting project where we had some really important findings. So the floor is yours, and I'm very looking forward to what you have to share with us.
Thank you very much, Elizabeth. I'll just start by sharing my screen, which I hope you can all see. Yes, great. Yep, so I will give a brief presentation on a policy brief entitled Building a European Health Union, Opening Borders for Intensive Care Specialists. This policy brief was part of a project we conducted within the Social Europe and Wellbeing Programme here at the EPC. And we collected opinions and research from by doing a workshop at the beginning of this year. And then also that was accompanied by some desk research as well. The workshop was made up of various experts working in the area. So to start with, just to draw attention to this, intensive care units across Europe and indeed across the world were really brought to the fore or highlighted or placed in the spotlight as a result, unfortunately, of the COVID-19 pandemic. And ICUs across Europe were faced with various challenges, including short supplies of critical goods, be that medicines, personal protective equipment, laboratory equipment. And it also really amplified or highlighted the pre-existing staff shortages that ICUs across Europe were suffering. COVID, of course, was not the root cause of these staff shortages, but it really drew attention to it as ICUs became overwhelmed with increased numbers of patients. And member states' initial responses, as we know from looking back to those early days, were very much concentrated at the national level. However, as some regions became overwhelmed, cross-border cooperation did start to develop. And in terms of ICU, this was predominantly to transfer of patients between regions, particularly neighbouring member states, where patients were transferred from one region to another. And what we really heard from speaking to intensivists, that it was a lot easier to transfer patients than it was to transfer intensive care specialists. But of course, this comes with risks as patients in ICUs are high-risk patients by nature. So it's not an ideal situation. However, it did help to alleviate some of the pressures that ICUs were under. So why was it difficult to transfer ICU specialists rather than patients, or more difficult anyway? And it's because there is not a framework set up to transfer ICU specialists between member states. Of course, as many of you know, there is the European Directive on the recognition of professional qualification, which allows for automatic recognition of qualifications awarded at the end of training programs, which are included in Annex V of this directive. However, if common minimum training requirements do not exist at the EU level, as is the case with intensive care medicine, then automatic recognition does not apply. So this really was a roadblock in the mobility of intensive care specialists across member states, and particularly during the onset of the COVID pandemic. So why and what benefits would it bring to actually remove these roadblocks and to allow for the transfer of specialists between member states? And one of the big things was that transferring intensive care specialists rather than patients would be preferable, and that could actually help to save lives and have less risks, to really mitigate those risks associated with transferring patients. Additionally, ICM specialists could move to regions in need of support instead of patients being relocated and potentially separated from their families. Family support is quite essential to intensive care, and it plays a big role. And in an ideal situation, it's better to have that cooperation and communication between the family support unit and the patient. Of course, during COVID, this wasn't possible for quite some time. And while solutions were put in place, it's been found that they weren't just as adequate as others. Additionally, ability to utilise and mobilise the EU's intensive care workforce in times of crisis. Of course, COVID-19 is one example, but unfortunately, it probably won't be the only crisis we face. And this also includes crisis based in a region, be that a natural disaster, where ICU units become overwhelmed with high level numbers of patients. So it will be a great opportunity to be able to transfer intensive care specialists from regions which are not under such pressure at such time. Also, to increase the attractiveness of the intensive care profession, we heard that, as is the case with across the workforce, unfortunately in Europe, attractiveness and retention is an issue. And this could help to increase the attractiveness of the intensive care profession. And lastly, to harness exchange of best practices and knowledge between ICUs across Europe. Of course, the patient is at the fore to all ICU units, and they're the #1 priority. And actually, by having the ability and the mobility between member states, the differences in health systems, it could help to harness an exchange of best practices and knowledge exchange, which could work in the best interest of the patient to provide the highest quality care possible to the patient. However, there is a challenge in bringing this mobility and having the free movement of workers. And the full recognition of intensive care medicine under Annex V of the Directive is currently not possible due to an absence of the majority of member states recognizing intensive care medicine as either a base medical speciality or subsequent to or within the existing medical specialities. So there are two main ways in which member states in Europe recognize intensive care medicine. So one is that it's a base speciality, and the other is that it exists subsequent to or within an existing medical speciality. And this acts as a roadblock, and it's not necessarily the differences, the divergence, the differences between how intensive care medicine is recognized is not in itself a negative. And creating one pathway does not necessarily need to be the end goal, but to try and create some sort of a framework where we can have mutual recognition of both of these pathways. So we came to the recommendation of establishing an EU training and competency framework, so that minimum EU training requirements and competencies could be established and incorporated into the already existing training programs that exist across the member states. And a common framework could establish minimum requirements for intensivists to practice in ICUs across Europe. A common training period could be established, and core competencies required as a specialist would be defined. So there is already a framework that exists, which could be used as a precursor, and that's the competency-based training in intensive care for Europe. And it promotes a common curriculum for doctors acquiring intensive care medicine competencies that last 2 years. So you could have mutual recognition for these intensivist qualifications. And there would be partial in nature, whereby member states in which ICM or intensive care medicine is a base speciality could be recognised, and once those training and competencies were met, and then also in countries where it's part of a base or dual speciality, it would be recognised, and vice versa. So that's kind of an overview of the policy brief. Of the recommendations that we put forward. And of course, it's also important to notice that there are other challenges associated with the mobility of healthcare workers, which I think we might touch on our later on in the panel discussion. And of course, not to ignore them as well, in terms of migration from east to west or south to north, and different factors like this. However, I'll hand the floor back to Elizabeth now, who will continue the conversation.
Well, many thanks, Danielle, for sharing these recommendations, and certainly also for setting the scene. Because especially in a point in time where there's a lot of discussion as to whether or not the European Health Union is a reality, the topic of health workforce and the mobility of healthcare workers is a really important topic. So We are going to start with a panel discussion, and perhaps in terms of practicalities, I just want to mention to the audience that we have proposed to the panel to come in with their interventions first, and then we hope indeed that you also will come in and we have a more interactive discussion. So with that, I'm very happy to kick off the panel discussion, and it's for a reason that we would like to start with Matthias Wismar from the European Observatory on Health Systems and Policies. Because Matthias, you have a long-standing experience in dealing with health workforce, health work mobility. And in that respect, I would like to ask you in your intervention to focus on what are the benefits and the challenges associated with the mobility of healthcare professionals, and also make the link with COVID-19. Because we saw the knee-jerk reactions of member states at the very start in March 2020, but then did the mobility of healthcare professionals eventually contribute to the response at European level of COVID-19. So with that, the floor is yours. We're looking forward to your contribution.
Thank you so much, Elizabeth, and congratulations to this research. I think you're touching upon very important issues, and it's not just ICU. I think it's much more general. It's about the European labor market for health workers, and it's also about our schemes for qualification. And we have unfortunately issues. Let me start with the labor market. We have a very vibrant labor market for health workers. And these are, of course, the 5 regulated professions. So doctors, nurses, midwives, pharmacists, and veterinaries. And as you say, it works via mutual recognition. So usually within a period of 3 months, you get your qualification recognized, which is very, very good. And we are probably one of the few regions in the world where you have this on such a scale. And people use it. They use it quite a lot. And even though we see crises like the economic and financial crisis, we have seen COVID, we have seen other crises before, the mobility doesn't seem to go back. It seems to be rather a little bit on the increase. Actually, it's very difficult to assess because we have difficulties to monitor the movements, but the mobility is here to stay, and it is rather substantial. So the question is it good or is it bad? And this is a very, very complex question because you need to ask for whom. And we have tried to develop a little bit of an assessment tool, you know, that you can think about for your own country. And we were asking basically, is it good for the patient? Is it good for the health professional? And is it good for the health system? And these are all involving complex questions of efficiency, but also ethical concerns. And then you need to compare sending countries and receiving countries. On the receiving side, you can easily figure that, you know, if a doctor or nurse moves, access is improved, while it might cause trouble in the sending countries. And you can also easily figure that the sending country, if it is systematically losing people, they have a problem with sunk costs for the health system. So they are training people, but somebody else is reaping the benefits of it. And the issue here is not so much whether we want to have the internal market or not. I think it's a great thing to have this internal market. The question is, how do we regulate this? And I think we can still do better. We can do better and offer, for example, international training cycles, because in some countries we cannot provide for all specialties training cycles for special, and then the danger is that people don't come back. We also have to talk about health systems reforms in countries, because if people leaving in large numbers, then they are leaving because they are dissatisfied with their own system. And it's not only the money, you know, it's sometimes the opportunities, the training slots available, and so on. So I think that this goes hand in hand. So I think there's still a lot of opportunity to improve the regulation of our internal market. There are suggestions on the table. Actually, years ago, the Maltese presidency was tabling a couple of actions on voluntary collaboration. So not everything needs to go through directives and regulations, we can also work together between countries, you know, sometimes using the framework, sometimes not. But I think there's a lot of opportunity and also some need to do this. Second thing, very briefly, but I guess that some of the other panelists will pick this up, is the acknowledgement of qualifications. And qualifications are becoming more and more complex and diverse. And actually for health systems, it's good. I just give you the example of the advanced practice nurse. These are nurses which, on top of their caring and administrative tasks, have also medical tasks, both in diagnosis and prescription. And how do you acknowledge these, you know, when they go to other countries, especially then that in some countries like Finland, you have very advanced practice nurses, so which really do a lot of medical stuff, while in other countries, they have a much more restricted prescription portfolio. So I think that the way we are acknowledging qualification was great in the past, but needs to change for the future. Thank you.
Well, thanks so much, Matthias. And perhaps one additional question before we move on to the next speaker, because in Danielle's presentation, it was clear that we have been focusing on Annex V of the Directive on the Recognition of Professional Qualifications. Do you feel that the inclusion of medical professionals in Annex V has, let's say, aided the free movement, has improved the free movement within the EU?
I think initially it certainly did, you know, because it makes it feasible, it makes it practical. Otherwise, you know, I mean, some countries in the past had more than 100 specialities, others had 45 or something like this. How do you cope with this, you know? Do you need to have your medical chamber checking it all the time in detail what this person can do? So I think in the beginning, it really facilitated the mobility. But again, it's a bit more on the doctor's side, and I think we need to have more flexibility and probably more modern systems which recognize more skills. And also, I heard this already in the presentation on the policy brief, and I can only fully support this. You know, when it comes to digital skills, but also green skills, for example, I think that we need to have some European curricula that is supporting this and make it much more comparable.
Well, thanks, Matthias, also for that additional answer. And with that, we're going to our next speaker, which is Dr. Ellen Kuhlmann, the president of the Health Workforce Research Section of the European Public Health Association. So Dr. Kuhlmann, we're very happy to have you as well. And for your intervention, I would like to pick up where Matthias left it, because especially with your experience on also working and focusing on health workforce, do you think that intensive care medicine should be included in Annex V? And could you say a bit more about the other challenges associated with the free movement of healthcare workers from your experience? So with that, I'm happy to give you the floor.
Yeah, at first, let me say thank you very much for this invitation. And as you already mentioned, I'm currently responsible for the health workforce group of the European Public Health Association, but I also would like to mention that this invitation was especially nice for me because before I became an academic, I was for 10 years an intensive care nurse. So it is still very, very close to my heart. Therefore, I was really very, very pleased when I saw this initiative, as I feel intensive care is at first, I totally agree, is extremely important. I mean, I felt always it has been very important, but now with COVID-19, there's much more attention to intensive care. There's much more challenges, and that is an opportunity also, yeah, to give the whole field a push also. And your initiative to achieve European recognition in the qualification directive is, from my point of view, a very good way, because Matthias, so I can only echo Matthias, that is a benefit, definitely. It facilitates mobility. And it also, that is one issue. The other issue, which I believe it also facilitates a standardization, and that is always also an opportunity to improve qualification. If you have defined standards, you can qualify more people and you can improve the standards. So the level of, you can improve the numbers and the level of qualification through these directives. As far as I saw it in the past. So that is definitely, I fully agree, that is the right way forward. And the other thing why I believe that intensive care is a very interesting example, because in the past, and that's also Matthias also already mentioned that, that we need new approaches to the qualification and the recognition and governance of qualification. And in the past, all professional groups have had this very strong, so very narrow view on defining their qualifications via excluding others. So that is a traditional professional track, and it is still very strong in medicine. But from our experience as healthcare researchers, we know that that is no longer the right way, because that's not what we need in healthcare. We need much more complex approaches, and we need to think from the needs of patient care and the needs of healthcare systems, and we can no longer come from the needs of a professional group and an interest-driven strategy. And intensive care has always been, per definition, very much more interdisciplinary, and that therefore it's a very good, it could be a kind of blueprint to accelerate these modernization processes more generally in the acknowledgement of qualifications, where we should no longer look at these only formal issues. What is your title or so, which is in the past. We should much more ask, what is actually your competence and what is your task, and what can this person do, and what kind of competences has this person, so is she or he qualified to do this, which is a different approach, and it's much more inclusive. And I believe that that is could be, or would definitely be, a benefit for the whole field, to have a professional group that goes through this process of recognition and inclusion in the directive with a new approach. And that also, I'm also involved in the public health debate, where the problem is even stronger, so that the public health profession is not recognized, and they feel that, and they are more diverse than intensive care. I mean, intensive care is very much connected to medicine, so you still have this medical advantage. Yeah, that's my main points for your first point. And the other challenges, I think there are very many challenges, and again, Matthias has touched on most of these issues. I don't think that I could add much on that, but just to mention and to reinforce these arguments, there are strong ethical issues. The internal market is definitely a benefit. That's absolutely clear, but at the same time, you all know that it also might increase inequalities. And my worries, especially now with COVID, or hopefully post-COVID soon, that it will exacerbate the existing inequalities, because countries are more and more under pressure. All countries are so much under pressure that they need healthcare staff. And then we have what we always see, there are these push-pull factors, and it's to the disadvantage of the less well-researched healthcare system. So we really need governance mechanism on the EU level, and circular migration, which also, again, Matthias mentioned that already, I think could be one opportunity. And there can be voluntary initiatives that's great. But usually you need some incentives to trigger these kind of initiatives. So from my point of view, it would be very, very helpful to develop more governance mechanisms, more programs, more research programs, and also funding opportunities that provide incentives for this circular migration. And I'm just currently doing interviews on a German project with Romanian physicians in Germany. And I was really surprised to hear how complex and diverse are their reasons, both to go to Germany and to go back to Romania. And there is a high also, there is a big interest from, at least from the people I talk with, to give something back to their country. So, and if there would be a program where you have kind of tracks or pathways, I think we could do much more to improve the circular migration and to improve the training, and these kind of things would be where I would hope that we can go in the future. Thank you.
Well, thanks so much, Dr. Kuhlmann, for sharing your experience, and especially knowing that you also speak from your own experience from the floor as indeed an intensive care nurse back in the days. And I think especially the last point that you mentioned is also very valuable about the brain drain that we see indeed in certain parts of Europe. And I think that is certainly something where indeed concrete actions to do with circular migration need to come in. So I'm sure that indeed that will come back later during the discussion as well. So thanks again. And with that, we go to our next speaker.
Thank you.
Professor. Thanks, pleasure, Dr. Kuhlmann. So we go to Maurizio Cecconi, the president of the European Society of Intensive Care Medicine. Professor Cecconi, very happy to have you with us this morning. The topic of today's discussion is particularly close to your heart. So in that respect, we are also really looking forward to your perspective. And also perhaps your suggestions about how the inclusion of the intensive care medicine in Annex V of the directive would indeed, let's say, benefit ICM specialists and ICU patients, because I think Danielle in her presentation really made that important difference that indeed during COVID we have seen experiences with patients being moved, whereas indeed moving specialists would make much more sense. So your opinion on this would be highly valued. The floor is yours, please.
Thank you, Elizabeth, and I also would like to thank Danielle for the research on this topic, because it explains very well some of the issues that we have now. And I would like also to stress again the importance of what Dr. Helen Kuhlmann was saying, that we need to take a patient perspective here. We are the professionals, but we are the professionals because we want to take care of patients and their families. And, you know, we talk about intensive care during crisis. Intensive care was born during a crisis, during the polio, epidemic. It was in Denmark in the 50s. And interesting, it was on the spotlight again some decades after, again during a pandemic. But we need intensive care for our patients every day. And even before this pandemic, there was already a crisis, in the sense that we know that with an aging population, with more high-risk surgeries, with more disease that we can treat now, and it's great, we need to have more intensive care beds to care for patients during the challenging times that they have. And in this sense, Europe, where intensive care was born, can set an example of also how you can become an intensivist with different training pathways. And we believe that that is actually is a great thing that we should value, and we should actually bring in a framework of recognition. This was already mentioned, but indeed, again, from a patient perspective, it was very nice to see the solidarity of European countries accepting intensive care patients during the pandemic. But that's probably not the best thing that we can do for patients and for their families. Remember that many of these patients were clearly very sick. Some they died in a different country. What we want is really to bring intensive care where is needed. So during a crisis, we should really try to find ways to move specialists where they are needed, in hotspots. But we shouldn't talk about this just for crisis. There are clearly shortages of intensive care specialists in Europe and other emergency specialties. And we believe that one way to attract more trainees, more doctors into these fields is also to make the job more attractive, in a way even more prestigious. If I go into a specialty where I know that, for instance, having some experience abroad is difficult, maybe I would be put off by doing that, while actually going and training abroad and maybe going back to my country after a while, which is a little bit my story. I'm an anesthetist and intensively trained in Italy. I then worked in the United Kingdom, and I came back to my country. I think the greater thing about Europe is that we need to promote the free movement of intensivists as much as possible. With this, we will share best practices, we will learn from each other, and ultimately what we will do, we will improve the standards of intensive cares across Europe, and this can only benefit our patients really and their families. So what is the challenge that we have now? The challenge comes from the strength itself, in a way, of the European system, where we have a lot of diverse training pathways to intensive care. In many places, basically intensive care is either part of the curriculum of a base specialty. Like for me, I'm trained in anesthesia and intensive care in Italy. In some other parts, this is within maybe medicine. In some others, is done on top of a basic training. And in some countries, also a base specialty. And what we want is to work together with everyone to find a framework of automatic recognition. Because if I want to go and have an experience in one country, and it takes only 3 months for my paperwork to be converted and I can work, I think that's great, that can work very well. If the process is much more cumbersome and then everyone has to review every single cases, and it may take years sometimes, then really the free movement is not there. That's why we need a tool, and we believe that the Annex V could be used in a novel approach exactly to find a framework for the recognition of all these different pathways. So in summary, I would say really that education, research, and sharing the best practices should really be some of the guiding principles to improve patients' outcome in intensive care across Europe, and really to promote the free movement of intensivists. And we have to do so really trying to move to an automatic recognition of the profession. And very important, I want to state this very, very clearly, we don't want to create just a primary specialty in the Annex. That would be wrong. That would not be in line with actually giving value to the different training pathways, to the multidisciplinarity of intensive care, which actually we believe is really what bring the richness of the training and the different approaches and from the learning from each other. We want basically every training pathway in Europe where we know that there has been a curriculum for competencies and enough time to achieve these competencies to be recognized, so that I can have somebody from a different country with a different pathway, but I know that is an intensivist coming to work with me, and vice versa. And in a way, we are already doing that with scientific societies, with clinical sharing groups. We often meet at European level. We have different stories in our training, but we value each other, and we know that we are equally competent when it comes to talk about intensive care. And we already create guidelines that can be used at the bedside everywhere. Now we need to find a way to bring this automatic recognition for the different trainings. So Danielle has already explained in the research paper that we need to find this way, because the majority of training, they are basically either within a specialty, on top of a specialty, or sometimes a primary specialty. We believe that the Annex could be used in a novel way to recognize all of this, and we really think that is the time to do this. And so if we achieve on this, I really think that we will do a service to our European population, remembering really that intensive care beds are just going to increase in proportion in our hospitals more and more. Our hospitals are going to change in the future. Probably they will be a little bit smaller, but with a lot of acute beds, and intensive care beds are going to represent a larger proportion of what it is now. So we really need to find a solution now to be ready to attract young, bright physicians to this. I think that then we should move also the conversation to other figures of the multidisciplinary team. I like very much the approach also about talking about advanced critical care practitioners, and every figure really of the intensive care teams. We should really promote the free movement for everyone that works in these multidisciplinary teams. I was often saying that a ventilator is not an ICU bed when the pandemic was showing a lot of shortages of these devices, but the reality is that a ventilator is not an ICU bed, because an ICU bed is a group of competent people working together. And I think we need to equip Europe with a tool for the free movement of these competent people in different roles, really to learn from each other. And again, to increase the standards of intensive care and ultimately to improve outcomes for intensive care patients and their families.
Well, thank you so much, Professor Cecconi, for sharing your experience also indeed from the ground with that different, let's say, national perspectives that you also brought into the conversation. I think also your remarks that I think in general, in a time where indeed technology plays an important role, but also the role of hospitals is changing. I think it's very important indeed to look also in light of the aging population and demographics that come in about how can we keep the workforce and adapt it indeed to the current context. So with that, I'm very glad that we also have the perspective from the institutional side with us. So we have Mr. Henning Ehrenstein from the Skills, Services and Profession Unit of DG GROW, your head of unit at DG GROW. So welcome with us this morning. We have been talking a lot about issues that usually fall under the remit of DG Santé, where indeed we discuss topics to do with the European Health Union. But we know that the current European Commission also tries to work very much across departments. And in that respect, it's really good to have your perspective, where you have a lot of experience beyond the healthcare sector to do with professional qualifications. So in that respect, we're very keen to hear your perspective and also perhaps learning from other workforce issues and what we can learn from these. So with that, I'm very happy to give you the floor.
Thank you very much, Elizabeth, and thank you for inviting me to this interesting panel. I certainly share the view of the importance of the mobility of intensive care specialists that several of the other panelists have already highlighted for the reasons that were mentioned and that became all the more evident during the COVID-19 crisis, though I concur that this is not just a crisis-related matter, but indeed we see a strong and high mobility across many of the medical professions. If you look at the database of the most mobile professions that we see in the EU, medical professions feature very highly. And that, of course, is at least in part due to the automatic recognition for many medical professions that applies under the Professional Qualifications Directive. In total, to at present 55 medical specializations. Of course, the intensive care specialists are not part of these 55, and that's exactly what begs the question whether they should be. Some of you have already referred to the fact that this requires an interest and cooperation of 2/5 of member states. So 11 member states would have to come together and say that they're interested in doing that, which in practice would require a harmonization of the basic training requirements, because only then can you be included in Annex V and can benefit from automatic recognition. So these two go together. I think no one disputes, and probably everyone, not just here in the room, but more generally agrees that it would be useful to have more mobility also for intensive care specialists. I think everyone would also agree with Dr. Cecconi when he says we should make this profession even more attractive and prestigious, because there's going to be more demand in future for it. I think on these overall principles, we probably all agree. The question is, for me, how to do it in practice. And if we look at the automatic recognition, then indeed we need to harmonize the training requirements. And the question is whether we can do that for 11 member states at least or not, given the diversity in the training and education of these people. So we have had some first discussions with member states in the fora that we have at our disposal for this, and to test the water and see what interest there would be. To date, we do not see that there is 11 member states that would rush into that. That is not to say we shouldn't continue trying, but maybe that's also not to say that there is not perhaps also other avenues that the Professional Qualifications Directive offers, in particular since its 2013 modernization, which introduced other tools to increase the mobility of professionals, where the general system applies, i.e. not the automatic recognition for the professions in Annex V. And one is to define a common training framework, because that's always the basis. You can only have an easier recognition if the training is similar. The more similar it is, the more harmonized it is, the easier the recognition is going to be, right? So the two alternatives that were introduced in this PQD reform to the automatic recognition was the common training framework, and the other one is the European Professional Card, which digitizes and makes much faster and more effective the process of the individual recognition of professional qualifications. So I would invite us to, on the one hand, continue to explore the addition into Annex V, but also see what other possibilities there are towards our, I think, common objective to increase the mobility of intensive care specialists. I would finally just like to pick up on a point by Dr. Kuhlmann that I thought was very important, and that is that while we, of course, want to foster and promote the mobility of professions in the single market, we have to be mindful of the inequalities that this can also on a regional level bring. So what was mentioned in terms of circular mobility or governance mechanisms, I think that would be very important to flank any policy, to complement any policy that we agree should be taken to increase the mobility of these professionals. Thank you very much.
Well, thank you very much for sharing your perspective. I think it's certainly very interesting what you mentioned. What I also thought was interesting is that you mentioned already existing tools such as the common training framework. And just out of interest, I don't know to what extent there is data available of the use of the framework, and also if over time already has been evaluated where this has helped member states within the current context.
Yeah, since these were tools that were not so long ago introduced, there is no ex post evaluation of their functioning available yet. So I cannot help you with this, I'm afraid.
Okay, something to certainly watch then indeed also later down the road when we keep working on this important topic. Really, thanks to all of you for setting the scene and for sharing your perspectives. I see that we already have some questions in, so in that respect, I also would like to turn to the audience because we're very happy to have you with us today. And we have the first question from Martin Beilik, the chair of the Czech Intensive Care Society. And Mr. Beilik, you're asking, and again, I think your capacity of the chair of the Czech Intensive Care Society is important to mention because you probably speak with that experience from the ground. You ask indeed about the majority of member states with defined curricula. And you mentioned the French Ministry of Health, where you felt that EU level, there are different opinions on the question. I would like to invite you because I think you have a wealth of information in one question. If you would like to elaborate yourself and ask perhaps the question specific to one of our speakers, I would like to invite you to perhaps speak up and take the floor if you want. And if not, again, and perhaps if I may, Professor Cecconi, the question is for you about indeed, do we know about the member states where there are not defined curricula in intensive care? Is there anything to say about which member states these concern?
I think the question is actually a technical question, probably more for the technician or the commission, but in terms of curriculums, our knowledge is that every state has a curriculum in intensive care. And this curriculum in intensive care is, for our knowledge, very comparable between member states. We started with European Society, a European funded project many years ago, which was called Observatory, which was also referred by Danielle in her research papers. But then after that, there have been European training requirements created either from that or in line with that. And you will find that the majority of curriculums are actually very similar for what concern the general requirements to become an intensivist. So if the question is around, what defines a curriculum to become an intensivist, we think that there is a lot of overlap in the majority of countries. What changes is the pathway to achieve those competencies. And in order to achieve those competencies, as we said, in some places, this is within a specialty. In some other places is above a specialty. In some others now is a base specialty. But in terms of what define the competencies to become an intensivist, our knowledge is that the majority of countries will have a curriculum which is very much aligned.
Does one of the other speakers also would like to come in on this point?
Maybe I can add here a little comment. I mean, we are talking here about medical doctors in principle, but as Professor Cecconi has said quite rightly, actually, intensive care unit is not a ventilator, it's a team, and part of the team are also intensive care nurses, technicians, and other people. And we've seen during COVID-19 a very agile health workforce, and that many nurses have upgraded their skills. Of course, they were not trained to ICU nurses in such a short period of time, but they were trained to support ICU units. And I think that's a great achievement, and it fills me with hope, because it shows that the workforce can achieve upskills and skill changes very quickly. But the question is, what is happening now with these skills, how they are recognized, both in countries, but also then when we go across borders. And therefore, I think that the example of the ICU specialist is very important for the entire health systems, because we will have more and more people delivering care coming from different pathways. We were discussing on Friday with the French Sickness Fund Association an example from a third country where they put pharmacists, unemployed pharmacists, to work supporting GPs, prescribing. And there will be many examples in the future. So I think that we need to have a much more flexible system to recognize skills and additional skills, regardless of the educational pathway. Thank you.
Many thanks, Matthias. I will see Dr. Kuhlmann also wanting to come in.
Yes, thank you. To continue with what Matthias said, I think intensive care would be a great example to develop kind of pathway or kind of ladder, which we are usually missing in all other areas of the healthcare system, where you can move step by step. Let's say, as an example, start as a nurse, then do some training, and then do some more training to get a formal recognition. And then maybe you could do some formal studies also and move up as a medical specialist. So that, because that's that's how intensive care is actually organized. As you said, that's a team. So and if we are talking about crisis also and COVID-19, then there would be teams. I think it would not have been helped if you only move 4 doctors or 10 doctors to another countries. But if you would have a team of, let's say, 10 people or so with the technicians, which are very important for intensive care, then you could move this team. And I think it would be a very great benefit for another country. And it would have solved a lot of problems. It would have saved lives, maybe lives of patients, but it would also have saved money, because it's definitely cheaper to move 10 people to somewhere than to move 10 patients to another country or so. And these kind of teams could also, in outside from crisis, they could help to develop training in other countries as a team. So that would be a very different approach. And again, intensive care could be a starting point and provide a blueprint then for other health professional groups. Thank you.
Well, thanks for sharing that perspective, Dr. Kuhlmann, because I think especially also in light of last week's report by the World Health Organization about health workforce, and where indeed it was clear that indeed more practical suggestions and programs are needed. I think this is a really important contribution. But let me go to other speakers and other questions, because we have some questions in the Q&A. And I just would like to mention to the audience, feel free indeed to put your question in the Q&A, but also feel free to speak up if you want and then elaborate on your question by raising your hand so that we can give you the floor. So with that, let me first go then to the questions we received via the question and answer. So we have Stefan Ehrman. What about increasing movement during training in order to have a global offer of a mobile specialty, increasing in standards and supporting the physician-free movement in the longer term? So I'm looking to the audience, who feels best placed to address this question? Yes, Professor Cecconi, please.
So I think it's a very good question, and I think it's exactly in line with what we think it should work at European level. If we really believe that we have to build a stronger Europe and a European Health Union, we need to be prepared also to have exchange programs also about the trainees going abroad to do some parts of their training, for instance, and then come back to complete this. There are already some tools to do this at European level. But I think to increase this mobility would be a great asset for Europe. And really, I believe that it will also increase the attractiveness of our specialty to potential trainees. At the moment, when you go to intensive care, maybe you know that you will be prevented to go and work or to train in other countries. We don't have to be scared about people going to work in other countries because they don't come back to our countries. If that's the reason why countries, they don't want to move with the recognition, I think it's a very wrong reason. We need to find attractive ways to bring doctors, the brightest doctors, to our specialty. And in order to do that, we need to bring the best condition for training and also for the free movement within training years and also after that. And often you see that people go, they learn, and very often they bring also skills back home.
And if you allow me, because I see that Stefan Ehrman posted 2 follow-up questions, so perhaps Professor Cecconi, this is also for you, because Stefan Ehrman also said it's unclear to me why the diversity of training pathways is such a hurdle to Annex V integration, and also in case of equal training across countries, recognition would be easy and automatic recognition actually would not be needed. What is your opinion on these questions? I see that also, I think, Henning Ehrenstein, you wanted to come in as well, and I also, Dr. Kuhlmann. So perhaps we start with you, Dr. Kuhlmann, and of course, did I see Matthias as well? Yeah, good. Well, then indeed we start, Mr. Ehrenstein.
Yeah, no, I just wanted to come in because this goes to the heart of the Professional Qualifications Directive, which is built on a mutual system of understanding between competent authorities in member states that regulate these professions. And then in the end, we take the responsibility for allowing a professional to practice her or his profession. So where they will admit someone to carry out that profession in a member state, these competent authorities need to be sure that that person has the adequate training as by the standards that apply in the host member state. And that is why you have as a basis for the automatic recognition, you have this common training, harmonized training standards, if you want, that apply. So even where you have this harmonized training, this is the basis for the automatic recognition that then takes place, and that really does facilitate the mobility of professionals. But because of that basic principle, you cannot say, if I harmonize the education, no recognition is required anymore. That would be a nice European dream and idea, but it's not the reality, whereby you have competent authorities in each member state that control access to professional activities, such as in the healthcare sector.
Thanks for that. I think Dr. Kuhlmann, you wanted to come in as well?
Yeah, just a brief comment. I think maybe we need a kind of dual track for that. On the one hand, try to improve standardization, which is definitely helpful, but at the same time, try to find ways to integrate this diversity, because intensive care is also a lot about technology. And I'm from Germany, so I think it makes a big difference whether you work in intensive care in Germany, in a German university hospital where you have high tech, or whether you work in some of especially Eastern European countries, let's say Romania or so, where you simply do not have this kind of technology. So it's impossible that you are trained in these countries. And if we would only go the standardization track, I think then something happens that we must really prevent, that we benefit only those who are coming from the resource-rich countries, and those from other countries that really most urgently need our support would be disadvantaged. So this is one point which I think is important. And another brief comment: there are programs, there are exchange programs, master programs usually, and social policies since longer that are funded by the EU programs or exchange programs, where you can do, let's say, a Euromaster in social policy or political science. And in order to get that, you have to move around to, let's say, 4 universities in 4 different countries. And that would, this kind of model might be also very helpful for intensive care training. That could make sure that if you are an intensive care specialist, you get a sense of how is it done, just as an example, in Germany, how is it done in Sweden, how is it done in Romania and in Italy. So, and there are EU programs, so it might be a good idea to say we also want to have these kind of programs for intensive care specialists. Thank you.
I'm looking, Matthias, did you want to come in as well?
Very briefly, I think that there are still quite some variation in the training of medical doctors. We are not fully aware of this, but if you see that some countries, for example, train pediatricians just for hospitals, others have different pediatricians for hospitals and ambulatory, some have it just one. Then we see different skill levels of dermatologists, and I could go on like this, and it's much more anecdotal, but there are variations in the skills and tasks, and that is because the directive doesn't go that deep into the skills and tasks. It's much more a generic and formal harmonization of the training. And I would also argue that you will also find some variation within countries, because teaching hospitals sometimes follow slightly different curricula in federal or decentralized systems, and they have also very different training approaches. So we need to be aware that there are, in any case, variations, and we need to think about how to deal with them smartly. And many hospitals do that. They have inception periods for new doctors coming from abroad, where they work in tandem with doctors from the country. And it's sometimes not only about the medical competences and skills, it's also to understand, the workflow, the administrative work, how the different elements in the health systems work together. So there are variations still in Europe, and the directive is trying to help this in a practical way. But I think that the question from the colleague in the chat was absolutely spot on, you know, so thank you so much.
Thanks, Matthias. And I think indeed going back to the questions, because we have 2 additional remarks from Martin Bejlik. If I'm not mistaken, that was our colleague from the Czech Republic. And I think your question has been answered in the meantime, because I think as Matthias just landed, there is variation in training. So the defined curriculum in an absolute majority of countries, I think, is in that respect perhaps still an issue to be addressed, as indeed Danielle said in her presentation. And then you also have another remark about the importance of patient safety and survival of healthcare systems. And I think that was really supported by speakers during their presentation. That is very important indeed. And you say then that we consume about 40 to 45% of the hospital expenses and deserve to be the first to surpass specialty, sorry for that, in Annex V. So I think that is indeed an important remark when it comes to also healthcare resilience and ensuring proper use of resources is ensured. Then I would like to go to the question of Eva Schaden. I think you have a really important question also about the next generation of potential intensive care physicians and how to increase attractivity. So thinking of their main target, which is very much work-life balance. And I think that is a really important point, especially in the current context with also European discussions focusing on the need of work-life balance and negotiations going on at that point. And you also say that you would like to emphasize the importance of distinguishing between intensive care medicine as a primary discipline in Europe, which is probably not increasing attractivity, from a common streamlined, which is more competence-based curriculum. So I think your question indeed is about the next generation and how indeed to balance these 2 aspects. So the primary discipline, and then let's say the work-life balance in relation to the discipline as such. So I'm looking at the panel who feels best placed. Professor Cecconi, you perhaps? Did I see your hand?
Yeah, I'm very happy. I think it's a very important comment and question. And I would like again to state again that our view is that we have to find a way to recognize current training pathway to become an intensivist. I think the automatic recognition or any tool that we bring to a fast recognition is something that we need to adapt to the current training pathways. We should not do the mistake to change the training pathways to be in this system. So in this moment, the reality is that the majority of intensive care specialists in Europe come from some multidisciplinary pathways. I am trained in anesthesia and intensive care, but there are also places where there are primary specialties, and there are places where different pathways or a primary specialty and a multidisciplinary pathway, they coexist. So we need to find ways basically to allow these intensivists, and I really believe it's so important for the young generation. So going back to what Eva was saying, it's so important to make it attractive for them to know that they go into something that will allow them also to have different experiences and so on. This is not the only answer to make intensive care an attractive job. We need to think why there has been a lot of burnout and a lot of tiredness during the pandemic. We need to understand how we create working conditions and make systems that are resilient for that. And this is a very important topic for the next generation. But back to the automatic recognition, we are talking a lot about competencies, and I completely agree that this should be the key. And we should find a way to put this in perspective for the recognition. But the paradox that we have now is that people that have competencies to be an intensivist in one country, unless they have their base specialty recognized, they cannot go and work in another country at the moment. So the reality is that we talk about these competencies, but we only look at the competence of the base specialty, not what makes you an intensivist. So this is something that I believe we really owe a change to the young generation. We need to find a way for them to move freely. Again, it would be a huge mistake to push everyone to go to a primary specialty in every country, but we need to be inclusive and accept the different countries for a series of reasons, traditions, politics, policy, and etc. They decided to have different training pathways. We should value them. We know that the majority have curriculums where are comparable, and we would accept them as good curriculums to become intensivists. We need to find ways really to accept this and to bring it to something that is either an automatic recognition or a very fast recognition for these young physicians to move across Europe.
Well, I think that's a very important point, Professor Cecconi, that you're making, because on the one hand, indeed, European healthcare systems are very different in form and shape. On the other hand, we also have been seeing, I think, since the creation of the healthcare competence in the Treaty of Maastricht, that indeed, over time, a lot of best practice sharing has happening and is happening. And I think also the training programs that our colleague from DG GROW mentioned are helping in that respect. So I would like to go to the next question, which sticks indeed a bit to the point about competences and standardization. Because Michel Chu, you are asking, how would this standardization be regulated? And who would be the governing body? How would this fit into existing training system in each country? So I'm looking to our colleagues from DG GROW. Perhaps, Mr. Ehrenstein, are you the one best placed to answer this question about the governing body and how it would fit in existing training systems?
I wish I would be. It's a co-creation process, together with the professions and the member states that regulate the access to these professions. So the first step that you need is an interest of 11 member states to go down this route. And then we would have, together with them and the bodies that regulate this profession in the member states, to see where are commonalities, and are these commonalities in the view of these member states and us sufficient to move into an automatic recognition. And indeed, one of the other panelists said, this is done in the directive, not in super granular detail, but it needs to be to a degree of detail that reassures these member states that they sign up, or at least 11 of them, to an automatic recognition. And that's where, that's the requirement we have to have. And of course, we as a commission can facilitate that, but we can't force it into the market, and we shouldn't.
Thanks for that. And with that, we answered the last question. So I'm looking at the audience. Is there anyone who would like to speak up? Additional questions to be put in the chat? Because if not, then I would like to go to one last round of questions and concluding remarks, if you wish, with our distinguished panelists. Because what really struck me as well in the report that the World Health Organization published last week is that they mentioned that actually there's quite a lack of data when it comes to health workforce. And of course, that is a hurdle to anticipate issues to do with workforce, and also hampers addressing workforce problems at member state level as well as at European level. So I would like to have your comment about, do we have enough data when it comes to, I think, the health workforce at large, not just on the topic that we're discussing today? And also, is there perhaps one practical suggestion that you have to indeed improve the situation of the health workforce, and especially, of course, in light of today's focus on the movement of ICU specialists? Again, perhaps if you could comment on the World Health Organization's remarks about the lack of data, and if you have any takeaway messages to finish this panel with. So perhaps we do it in the order that we started, to be sort of democratic. Matthias, feel free to kick off.
Thank you so much. I feel terribly boring talking about this topic, data, because it's a dry topic, and also because we are talking about this for years and years and years. And I have to acknowledge that the data has improved over years, but it's still quite bad, unfortunately. And it starts with simple things like some countries have full-time equivalent data, others have only head counts. In Poland, every person is working full-time. In Netherlands, there's nobody working full-time. We have no clear understanding what makes actually a nurse. We have many countries that report still people that have retired or no longer are in the workforce. So we have quite a mess. And the mess is also a mess for countries themselves. You know, how many working hours do they actually have in the system? They don't quite know. I look at my own country, Germany, and we have unprecedented levels of numbers of medical doctors in the system. And we are still discussing, are we have enough, you know? And the issue is because we don't quite know, because so many are working part-time and not full-time and doing other jobs and so on. So we have here a mess, and I think that clearing up the mess would be extremely helpful also to understand just for countries, you know, for countries when they talk about the performance of their health system, how many people do we really have in the system that are working, and of what cadre actually, and what are the good ratios between medical doctors, nurses, other health professions, and so on. At the moment, we have no conclusive answer to this. And I do believe that the European Union, but also international agencies like WHO, have a genuine role in this, you know, helping to improve register methodologies, because the problem lies in the countries. You know, the problem lies really in the countries that they are reporting data which is produced by different definitions, by different register methodologies. In some countries, we have a kind of Chinese whisper that medical chambers send the data to statistical offices emulate the data whatsoever. So it's not so good, and it's also not good because it's not timely data. And when we talk about health professional mobility, we would really like to know where people end up, you know, and it's not so easily done. You know, you need to go individually to national registers to do this. So my boring request here is, please, let's invest a little bit into improving national data and improving EU data on it, and give the EU a little bit of a role of monitoring both the process but also the health workforce, because we have a common European labor market, but there's a lot of fog in this labor market, and it's the role of the EU to clear this fog. Thank you.
Thanks, Matthias. I think that's a very strong metaphor that indeed clearly illustrates the issue at stake. Dr. Kuhlmann, anything from your side to share?
Yeah, thank you very much. And to continue, I think I totally agree. We need more data, and there are very, very strong gaps. But at the same time, my main point would be we need other data also, because the data have improved, but it is monitored and documented what we would have needed maybe 10 years ago or so. And I see 3-4 really strong gaps that are very serious. That is not any kind of order. I see gaps that we nearly no data have on teams. We are talking about skill mix, we are talking about teams, but we don't have data on that. So to my knowledge, absolutely nothing. There's a depth of knowledge. Then we still have a lack of data on gender. It has improved, but it's very often only sex disaggregated or not really gender-based data. The third point is the migrants, which I think is a really very, very serious issue. And during COVID-19, we know that the migrant healthcare workers had very specific needs and challenges. And we do not even know, to my knowledge at least, we do not even know how they are affected by COVID-19. We do not even have basic data. It is just in a process of improving, but which I think is really a serious issue and is a very serious failure. And and lastly, no, not lastly, the other point is that to my knowledge, in most countries, if not in all countries, the small medical and nursing specialties totally fall through the grids because so a small friend, to give you an example, is rheumatologists, also these groups that are important, but they are very small in numbers. So you cannot easily find data on them, even in countries with very good reporting systems. And as a very general comment, I believe that health workforce monitoring and data have been so strongly focused on health labor market approaches, because that is most easily can most easily be documented. But at the same time, we know that that is not enough. And that is something that Matthias has also been involved that we did with the European Public Health Associations group, where we called it, we must have a look at the human face of the health workforce. And COVID-19 has increased this need to take a different approach, because as others already mentioned, their stress and burnout have seriously increased. And if we don't find ways to respond to that, then we will lose a lot of people, very well trained people in future. So we must find also other kinds of data and other perspectives to expand on the way that on the designs of health workforce data and monitoring. Thank you.
Thank you, Dr. Kuhlmann. I think very important points indeed about additional training, also well-being, burnout, a really important issue to also indeed focus on when it comes to data, as well as indeed, I think the point about people with a migration background, which are so important also when it comes to the more, let's say, informal care sector and the healthcare sector at large, I think is a really important point that we need to study more, I believe. Professor Cecconi, we go to you, please.
Yes, I agree with Matthias that we need more data and we don't have enough data, but the very little data that we had before the pandemic showed that there is already a huge variability of intensive care beds in Europe, and also how these intensive care beds are staffed. But what the agreement is for whatever we have in terms of numbers is that we know that these are the areas and the bed with the highest intensity and concentration of working personnel. So they're very high resource intensive areas. And we didn't have enough nurses, doctors before the pandemic for the needs of an aging population and what we discussed before, and the fact that healthcare is going to become more complex and there is going to be a larger need for caring for more intensive care patients in the future. So a lot of the response during the pandemic from governments everywhere in the world has been trying to put more money into this. But if you put money, but you don't find ways to attract the people to work in these places, you're not going to solve the problem. So I really urge the European institutions to think about a blueprint on how to really to solve the problem of the recruitment and retention of healthcare workers in intensive care unit, in emergency medicine, in all these acute areas where actually the problem of not having enough human resources was known even before the pandemic, and the pandemic has just put the spotlight into it. So again, for me, today we were talking about the free movement of intensive care specialists. That could be one of the tools to make the job more attractive. It's very important. It's not the only one. We need to think really that different jobs that may need different solutions. And I really think it's time to think now, because even without the pandemic, the needs for intensive care beds are going to be there. And it would be naive to think that we can just train nurses or doctors in intensive care, just be giving them crash courses. We did that during the pandemic to help in an unprecedented situation with our society and the support and funding of the European Commission. We trained 20,000 healthcare workers not working regularly in intensive care. It was an amazing project, an example of solidarity across Europe. But that helped in an emergency situation. We cannot expect that to be the standard of care for our patients normally. For that, we need a more long-term solution, proper training with the right amount of time, and again, making the working conditions for our healthcare workers attractive.
Well, thanks for that point. I think indeed very important. Forward planning and not just in the midst of a crisis situation, I think is indeed, I think one of the lessons learned if you look back about healthcare workforce and how that has been addressed at EU level. So Henning Ehrenstein, anything from your side as a final remark?
Yeah, look, I think none of us, would disagree with the statements that this is a profession that is of societal importance to ensure that it's attractive to young people to go into and to practice. And I think none of us disagrees either with the point that the opportunities that the internal market can offer in terms of mobility of these people, especially for young people, is one of the factors that will make the profession more attractive. The question is, beyond these statements, how we can do it in practice. And the automatic recognition, it's nice to say Brussels needs to do something, but the rules that member states in the European Parliament give us are that we cannot if we don't have 11 member states that want to do it. And we don't have 11 member states. That's why I was giving you as a potential alternative options, raising other opportunities that the directive offers, such as the European Professional Card that we have introduced for several professions, and where the feedback from the market so far is that it works quite well, because you still need an individual recognition of your qualification, but it's a digitized procedure that is much faster to operate and will bring quicker results for the people that apply. So we are very happy to continue working with you and with member states to get to what I think is our common objective. But of course, we'll have to do so within the rules that the co-legislators of the European Parliament and the member states give us. Thank you very much.
Well, thanks to you. And with that, we really come to the end of a very interactive and very interesting exchange. I really appreciated the intervention of all of our speakers. You really brought very important information from the ground, your own experience having worked at member state level, as well as the more, let's say, institutional and policy perspective about thinking about opening border for intensive care specialists. But I also really appreciated that we addressed the issues about the health workforce at large, because I think that is in the current context with an aging population, demographics that are changing, a very important point to keep on the agenda, really. And in that respect, indeed, the need to also further look at data and ensure that we collect the right data is also for us at the European Policy Center a very important takeaway. So let me thank all of you for being with us today. Let me also, of course, thank my colleague, Danielle Brady. Danielle, you're setting the scene, the recommendations that you put forward were a very important inspiration for the discussion that we had today. So thank you very much for that, and also for leading the project that we had in the past. Just to say that at the European Policy Center, and especially in our program, which is called the Social Europe and Wellbeing Program, we do a lot of work on European Health Union, but also broader questions to do with health workforce, the skills agenda, training. So in that respect, I would like to call on, of course, our speakers, but also our audience to keep following the European Policy Center. If you're not yet subscribed to our newsletter, please do so. You can easily do that via our website, because we have a lot of events and also projects in the pipeline that are to do with the topics that we discussed today. So I really count on you and hope that we will see each other again in the future. So many thanks again, and wishing you a good rest of the day. Bye-bye.